Jadi sesi kali ini adalah tentang kaunseling pemberhentian pekerja, manfaat kepada majikan dan pekerja. Okey, boleh kita mulakan dengan satu konsep ataupun pemahaman tentang apa itu penguncupan saiz dan di mana ia berlaku serta mengapa ia berlaku, Doktor.
Okay, so good afternoon, everyone. Since we're going to use BM and English, all right? So since there are not many people sign up who want to speak straight in BM, we can use the English as well. No worries.
Okay.
All right. Yeah. So, but if anyone don't understand English, you can ask and we can explain in BM. And we will use this as a case study to look at how the retrenchment, so what you are saying, penguncupan
saiz,
penguncupan saiz is like downsizing.
Yes, downsizing, Doctor.
Yes, downsizing and will cause a lot of anxiety, right? And it is a situation whereby there would be the use of substance abuse. So we're going to use it as a case to look at those. Yeah. Yeah. So what is your question, Liana? And what is downsizing?
Okay. Yes. What is downsizing? How it happened and why it happened, Doctor?
Right. Okay. So downsizing is happening because of this COVID situation. So certainly, company needs to survive, right? If you go to the mall, you can see that there's no one there, and I mean there's some people there. For me, it's very nice. And even no one is flying, so lots of company suffer. All right. So we were in a company a few weeks ago, in an aviation company whereby they need to retrench most of their staff. Right? Imagine like 90% over they need to downsize because no one is flying, right? So they have to do that. So because of that, this is why it needs to be done, and it creates a lot of anxiety, right? With employees. That is why the downsizing and retrenchment is causing a lot of psychological issues. All right, for there are a lot of anxiety amongst employee that fear this downsizing, right? And we have something called EAP, Employee Assistance Program, which started in America, right? It is a way to look into the problem of addiction. So EAP started in US because of addiction problem, right? So there are a lot of workplace substance abuse, alcohol abuse, and as a result, companies is really affecting the performance, the work performance of organizations. So they call in counselors to do screening and then to help employees with this substance abuse problem, right? So this is how EAP started, but now EAP look at all sort of stress issues for employees. Right, and certainly retrenchment anxiety is one of the issue. So we use EAP to help organizations, with retrenchment issue and downsizing. By the way, the others, you can just ask your question whenever you have any question you have. You can use the chat to ask directly. We're having a small group only, so feel free to ask at any point. Okay, so that is the issue with downsizing and retrenchment. Yeah.
Okay, Doktor. Jadi berbalik pada EAP tadi tu, maksudnya you're saying that currently our program, our EAP is conducting the sessions for this retrenchment counseling.
Yes. It include as part of the issue, right? Employee can bring any issue to EAP, employee assistance program, that they can bring any issue, and the anxiety about retrenchment is certainly one of the top issue that the employee can bring to their EAP, or even if they have a addiction problem, they can bring to the EAP. So this is how the EAP work, right?
Basically, how does this downsizing is affecting most of our organization and the workers, Doctor?
Right. So we discussed a little bit about that in the previous session. It affects people differently because they have different schema, different perspective. All right. Just now we were doing an exercise about rescripting some of the schema. So I didn't have a chance to look at that. Maybe this is a good opportunity. Haslin, I don't know whether Hazel, you're here. Let's see who is here. Azuddin, okay. Puwana. So if you are here, you can show us some of your rescript, right? So we can have a look at that, what you have done on your rescripts, and we see what we can do, why we have this different resilience. So do any of you still have your picture with you? Haslin and Azuddin, Hazel. You can have a look at that if you guys have your picture with you. We were doing a bit of schema rescripting just now in the session there now. All right, because we were talking about resilience. How come different people have different resilience with all this downsizing and stress? So yeah. Azuddin, you have your picture with you, your photo you want to show us? Yes.
Yes, I have.
Right.
Okay.
So yeah, tell us what is this about?
Okay, this is me. I think it's when I at the 15 years old.
Yes.
I think it's when I have a family problem, which is my family control everything about my life, and including I cannot meet my friend. Just I go to school and I going back to home. Only that things I can do. I can did, and then it's give to me stress, and then I feel rebel, and I think I almost to run to my home, to my friend home.
Right. So that is the painful memory.
Yes.
Right.
Yeah.
Did you manage to change it?
Yeah. When I grow up, and I think is because I think I try to change my mind to the positive things. I think maybe my family don't want me to have maybe bad attitude, maybe bad the personality. I friend with the bad person, and I have a discipline, or the maybe I involved in criminal. I think lah. I think I try to turn to the positive thinking.
So you yourself try to do that. Okay, very good. But what we need to do is, that memory you have given us, we want to modify it. Okay. So if you can try to change it, put some like words or other images on it, or do even a new drawing on it, Okay.
I think my friend is give me the motivate. My
Ah,
best friend is always
okay.
give me the support.
The
He all
smiling. Ah,
yes yes
right, right.
and give me
Very
the
good.
happiness thing in my life.
Right, right. So what are they saying to you? What is the phrase from your friend? Be patient.
Be patient and then just follow the every all the family all the family need from me, and then after this maybe you can realize what they want actually.
Ah,
And
okay.
then my friend always give me they encourage me to the study hard, prove to them you can be a good student at that time.
Hmm. Right, right. So the you can do it. You can still be a good student.
Yeah,
Be patient
yeah,
and try to meet the needs of your family members.
yeah,
You know, and maybe there's some good there.
yeah.
Sounds like you have very mature friends.
Yes, I'm
That's
very
good.
lucky.
That's good. That's good.
Okay.
Right. So this is an example, right, from Asudin of how he can develop the resilience. But a lot of people might not be as lucky as him. So that is why they have a lot of this problem with the downsizing and retrenchment, right? So then we need to help them to change to maybe even be a bit of a like the parent to them that they did not get, like this good friend, right? We need to be like this good friend to the patient that did not get when they were young. Yeah, so this is what we need to do to help them become more resilient, right? To overcome the anxiety or the addiction problem that they have, right? So this is the other thing about the addiction disease, right? So the substance has becoming like a friend to them. So that's why they turn to substance. So the substance is their friend now in dealing with all the stress, right? So if you want to take away the substance addiction from them, we need to give a replacement, yeah, to this patient. You know, we cannot just take it away and then they have nothing to rely on, right? So we need to always come up with a replacement, with an alternative to help them deal with the stressor, right? So that is the therapy we need to do, you know, in terms of helping with anxiety and addiction therapy, because it is becoming a dependency, right? To deal with stress. So that is what we call a psychological dependency. Yeah. So it is as powerful as the physical dependency. Okay. Good. So anyone else have any question about this issue? Um,
Yes,
anyone?
Doctor.
Yes.
Tentang replacement tadi,
Yes.
the substance addiction, and
Yeah.
then you said that there must be a replacement. So what
Yes.
kind of replacement do, Doctor?
Yes. Good question. What type of replacement? Okay. We need to understand first of all why someone engage in the substance, right? Um, and in fact, there are different type of substance, right? There are stimulants. So we earlier we talked about the neurotransmitters, right? Just now from this nice book that I don't have with me. Ah, yes, you know, from this Vanita's book, we talk about GABA, which is a relaxant. So GABA is a relaxant. So some substance like alcohol actually stimulate your GABA, right? It's a GABAergic activator. Other substance like marijuana, is a stimulant. It will increase the dopamine, right? Your noradrenaline. So different substances have different effect. We talk about mood altering substance. So there are so many different substances. We need to understand how each of these affect different neurotransmitters. So when we talk about replacement, we need to know specifically what neurotransmitter those substance activates. All right. So if it is a stimulant, which is increasing our dopamine, you can find an activity that increases the dopamine, like music is a very good activity that increases the dopamine, right? You can find music as maybe a good replacement, or even a sports. Someone was talking about a sports, and we can use sports to increase dopamine as well, right? Like I like to play tennis, and you would increase the dopamine, especially at a game of double when you can relate to others. But on the other hand, if we're talking about depression and a relaxation type of stimulant of substance, then you need to find a relaxing, type of activity, like doing a yoga, for example, having a massage would increase your GABA, or doing some bonding with people. So there are different activities that can also be a good replacement, depending on the substance. And of course, we can also use supplement, psychonutritional medicine to do something similar, right? So like dopamine, we can use L-DOPA, which is a precursor to dopamine, to increase that. We can even use GABA directly, which is an amino acid, to do that. So there are many different things we can use as replacement when we know more precisely what are the neurotransmitters that this substance is activating. Then we can customize the replacement more precisely. Okay.
Yeah, doctor. And just now in our previous session, you mentioned something about pain. So I last 2 3 days, I went to complementary health center, whereby they offer this service to treat people with heart disease, or all those empat serangkai penyakit tu, doktor, diabetic, kidney, heart, and hypertension. So I went there, and they actually offered apa nama tu, they call it micro test, something like that. But bila saya pergi sana and I did the test, so what they did was they used there's a machine to scan my blood capillaries. So from there, they read that my hypertension is quite high, and my blood capillaries they are predicting that I might get a heart attack. Okay, from there, doctor, I was asking myself, does this prediction or pain that I'm having on my back, or even the muscle on my left side of my body, would relate to these neurotransmitters? Because the pain that we are having on our body is actually rasa sakit tu sebenarnya kita rasa melalui neurotransmitter ke, atau memang ada something else yang buat kita rasa sakit tu, doktor? Because of the muscle yang buat otak kita translate sakit itu yang buat kita rasa sakit, atau apa orang kata tu, sebab neurotransmitters ni ada kaitan dengan saraf kan doktor?
Yes, talking about pain, it is what we call half physical, it's psychophysical, right? So you have probably heard of disorder called ME, or fibromyalgia. Have you heard of fibromyalgia? Right?
I think I've read it somewhere in DS5.
Yeah, fibromyalgia is it can be a very painful disorder. All right, but the cause of it is unclear.
Okay.
All right, so it could be definitely neurotransmitters related, like serotonin. If you're deficient in serotonin, it can make you vulnerable to pain. But at the same time, when stress increase, the patient is also more vulnerable to pain, right? So it could be partly psychological, partly physical, right? So definitely therefore our treatment can be that, and now we even have energy medicine, to deal with that. But so what we can advise the patient is to do a measurement of the neurotransmitter. We have a urine test that can measure, all the neurotransmitter. I think we need to mute you again, Liana. Okay, so we do an assessment of all the neurotransmitter and see which is deficient. Maybe the serotonin is deficient, then we will treat that and boost that up. It's very easy to boost up the serotonin. All right, and this is the reason why probably patient use substance in the first place. They're trying to treat themselves. They're trying to medicate themselves. So maybe originally they have some of this pain issue. Maybe they have a deficiency in certain neurotransmitters, or maybe they have ADD. Then they naturally then resort to using substance, or maybe they have anxiety, right? And then they use substance because like you use alcohol, then you relax, your anxiety come down naturally, right? So some patients they treat themselves naturally because they find that works for them. It helps them to function after they have a few drinks. They feel less anxious, and they function better. Then that's how they become addicted, right? So to treat, we need to find out what naturally you are deficient is, and then find the form of treatment that is working better, that do not get you to become addicted, right? That's now if you don't drink, wow, the problem with using substance is the addiction. So what is the problem of addiction? Anyone know? Why is addiction a problem? Can I just hear from anyone?
Causes dependency.
Yes, causes the dependency. What can you define that? What do we mean by dependency?
For instance, like sleeping pills that helps them sleep, and then when they don't have the stock, what happens is they can't sleep at night, and which leads to a lot of other issues like high blood pressure and so on.
Right. So so dependency is when if you stop it, you have something called withdrawal symptoms.
Withdrawal symptoms, yes.
Withdrawal symptoms. All right. So and this is why it doesn't even have to be sleeping pill.
Mm-hmm.
Okay, so that is why you can become addicted to anything. You can be addicted to gaming. You can be addicted to gambling. You can be addicted to the sex, right? So that means if you don't have it, you have withdrawal symptom. All right, you can be addicted to love. Some people have love addiction. So it causes withdrawal symptom when you don't have it. And that is what we mean by dependency. All right, it causes withdrawal symptom. And the other problem of the addiction is it has a tolerance effect. Anyone know what is tolerance effect?
Maybe the body getting immune to the substance.
Well, this is to do with dopamine functioning. All right, we talk about dopamine, right? Dopamine is a reward pathway. You need a certain behavior or substance to boost it, right? But it always need a higher amount, right? So if you have a type of music, you listen at first, you really like it, you really find it fantastic, exciting, but you play the third, second, fourth time, it doesn't do it for you anymore, right? So this is how dopamine function. It always look for new, novel experience, and it is like this for a reason, so that as a species, we keep on exploring things. Otherwise, we lose the motivation to try new things, right? So it has a survival value, but it becomes a problem, when we get addicted to substance, because we always need a higher and higher amount, right? So this is a problem with addiction. You need a higher and higher amount, and until your whole brain becomes diseased. Yeah. So addiction has this few problem: withdrawal effect and tolerance effect. It's then it becomes harmful to us, right? So we need to find a replacement that deal with these two problems, right? So it has most things. There's a writer called Oscar Wilde, he is a British writer, and he said anything that is pleasurable is addictive, right? So anything can be addictive, it is pleasurable. So I think then it doesn't mean that we don't do anything pleasurable. You just need to have a balance. You need to keep your life balanced, right? You don't like focus on one thing. You go. So I go and play tennis, but I do other things. You don't like depend on one thing. You don't put all your eggs in one basket. So this is how we deal with this pleasurable. You need to have a lot of different pleasures and not just one pleasure. So that is how you deal with it. So you don't become over focused and on just one source of pleasure. All right. So that is the thing on the addiction, right? The other thing is we talked earlier about in terms of CBT. We talk about CBT is linked to the negative prediction. Anxiety. Anxiety is about the idea of anticipation. Negative anticipation, right? So how do you counter that when you identify that the patient has some negative prediction about the future?
Basically, the drug addicts, they have a false belief or irrational belief or thinking that lead the patients, the drug addicts, to drug addiction. So we can basically there are a few techniques to identify how they have a how to identify their irrational beliefs, because usually during the initial interview or the intake interview session, I can say that almost 70% of the clients, they have a false thinking or rational beliefs that lead them to involve in drug addiction.
Yes. So any one of you heard of the 12 steps program? 12 steps is very famous for addiction therapy. Look it up, 12 steps. All right.
Sorry, comes again?
The
What's that?
12 steps program.
Yes, 12
Yes.
steps rehabilitation programs that
Exactly.
employed by Malaysian prisons.
Well,
But I don't think it's effective actually.
yeah. But the variants of that can be incorporated. But the first step is what, if you remember? The first one is where you have denial, right? Yeah. So you deny that the behavior is a problem, right? So this is the first thing. In fact, it's the first thing in all counseling and psychotherapy. Is to help the patient overcome denial. Okay, so the patient need to be able to accept that they have a problem, right? So yes, so there are all sort of irrational belief, right? And this is why CBT can come in to identify what are the irrational beliefs. In fact, if we Zoe, you have the treating anxiety and depression book. Okay, bring me a copy of the book. So I would recommend you this book, which we already showed Azudin, you know, by Dr. Daniel Amen. I'm treating anxiety and depression, right? I'm licensed by Daniel Amen. He wrote the book called Healing from Addiction, right? But this is which is out of stock. But if you go up, you can get me that there's some CD called Unchain Your Brain. Yeah, it's a white cover CD on the right hand side of the room if you face the room on the right hand side. Yeah. So Daniel Amen, he so this is his other book, Treating Anxiety and Depression. I highly recommend it. And here he talk about ANTS. All right. ANTS, ANT, which stands for automatic negative thoughts. All right. Yeah. So there are different type of ANTS. All right. So why is it difficult for patient to change irrational belief? First of all, it's because it is automatic. It's like they cannot even stop. It's automatically happen, right? It because it is due to the schema. When you have the schema, then all the negative thoughts get triggered when you have a stressor that trigger it, right? And then secondly, it is very subconscious. They might not even be aware of it. So that is why CBT is helpful. You help the patient to be aware of all these ends, automatic negative thoughts. All right, and then you tell them, you know, what is the irrationality is about. So for example, N number 3 is called the red N, and it is fortune telling, you know, N number 3, you can see. The red ants, and so this one is about crystal gazing, right? You crystal ball gazing. You this end occur when you predict that bad or negative things will happen. Fortune telling and underlying most anxiety disorders, especially those with panic attacks, right? So this is a very relevant angst, you know, in anxiety, because you automatically predict the worst case scenario of something. But the challenge here is to help the patient realize this is irrational, right? So like what community did just now on her case, you need to like do some Socratic questioning, you know. Anyone know what is Socratic questioning is? No?
Questioning.
Sorry?
We ask a few sets of questions to challenge, to challenge the ideas of the client.
Yeah, it comes from Socrates, which was an ancient Greek philosopher. You can looking it up, but it's a set of questions that challenge the assumption of the patient. You know, how would someone else see it? You know, so this is what the company was using just now. So the way you question it, then will help the patient discover the irrationality of their belief, right? And Socratic questioning is the key there, because if you just tell the patient, look, what you have is irrational, then what is the problem with that? What is the problem with that? If you just tell the patient, you know, you just have an irrational belief, what you have is irrational. Any problem?
They will stop talking to you.
Exactly, exactly. You're right. This is the difference between a counselor, a therapist, and a lecturer, right? Yeah, they would defend against you. If you would tell them you're wrong, you know, you're bad, they will defend against you. So that's why we need to use Socratic questioning. You need to like question them in a way that they themselves start to see it is irrational, without you telling them it is irrational. How would someone else see this? You know, you ask them in a way that they see the internal illogic of the situation, right? So that's a way to deal with. First of all, you need to help them identify all these irrational thoughts, right? And then to see it for that themselves, right? So you need to help them to surface it themselves rather than you telling them that it is irrational, so they can accept it, right? More readily. So there are different type of irrational beliefs, but there's no point you telling them. You need to help them to discover that themselves, all right, step by step. So I would suggest that you look into this. There are different type of ends. There's fortune telling, there's mind reading, you know, that can give rise to all these irrational belief, which Haslin, you're right in pointing out that the patient might have, which keep them to the addiction, right? So they are deluding themselves with a lot of irrational beliefs. Yeah.
I think the Socrates questioning, most of them would be why? Because we are challenging the assumption, doctor?
Yeah, we are challenging their assumption of so that they can see that the assumption is erroneous, is irrational. Yeah, you're right. So you know they have an irrational belief because the assumption itself is irrational, right? The very foundation. So you're helping them to question themselves so that they can then challenge that. Yeah. So that is basically the technique of CBT to deal with addiction and anxiety and many other disorder, right? In addition to what we were talking about, using more experiential technique like changing the whole memory, the whole schema.
Doctor, we know that it's not easy to challenge and change the client's negative thoughts. So what about the mindful technique? We use a mindful technique in order to focus on positive and thinking, for healthy thinking skills for the drug addicts. So what is your opinion about the mindful techniques?
Yeah, so there is something called mindfulness, right?
Yeah.
Mindfulness therapy. Yeah, and indeed we also have a course on that. That is by John Kabat-Zinn, I think. So that is something that is borrowed from Buddhism, right? That you get. So this is the thing, all right? When we talk about trauma, we had a brief chat about trauma just now. So why is trauma so harmful? The word is I don't know what's the Malay word for it, but the English word is the debilitating. All right, debilitating. Why trauma is so debilitating? It's because the part of the brain that enable us to be present, enable us to in fact go back to the past, all right, and look at it. The part of the brain that enable us to look at ourselves is like gone, you know. So the victim, the trauma victim, cannot do that. So when they look at the past, it's the past. The past become real. They cannot just like go back and look at the past, right? So this is where so they've done brain scan and look at that part. You know, when you become self-aware, there's a different part of the brain that becomes activated, and trauma patient cannot do that. Yeah. So then we need to definitely help the patient to redevelop that part, but it's not easy because that part of the brain is like we need to reclaim it. That doesn't mean we cannot rehabilitate that part of the brain, right? But so to do mindfulness is difficult to start with, right? So you get a trauma patient to do that. It is almost impossible to do that, but it is a good goal to have, right? So you need to do it step by step to be able to do that. You know, someone talk about EMDR. You know, that's a good way to slowly get back to free up the working memory. So the problem is the traumatic event is taking too much of the working memory. So you need to like get the, so how EMDR work, by the way, you know, and I would recommend, you know, the course that we have coming up, you know, check it out. How it work, why it work is because we are taxing the working memory, right? So you have a limited capacity, the working memory, right? So when the problem with the trauma patient is it's all filled up with trauma, with the trauma memory. So that's why they cannot have the resources. They do not have any more working memory to do other things, to be in the present. All right. So what EMDR do is they look at the finger and you focus on that. Then it wipe out all this working memory, focus on the past, because you're focusing on the present, because you have limited working memory. That's how it works. So then you reclaim back more and more working memory for you to use, you know, to be functional and to be less slave to the trauma. That's how it works. Okay. So yeah, mindfulness is useful, but we need to find a way for it to be able to be practiced, because it's not easy for trauma patient to use. Okay.
So doctor, back to the trauma, I was going to ask, how about deeply imprinted experiences? For example, there have been some of my friends who speaks of black magic experience. So these kind of things, and then of course it started from childhood, where the parents or the relative practices such things, and then they begin to start living in fear. You know, every small thing is related to the black magic. Yeah. So what do we do with that?
Well, so this is linked to the irrational belief, and this is what we call magical belief, right? A magical belief, which is part of irrational beliefs. It is also linked with schizophrenia, you know, some psychotic psychosis, that they all have this delusional magical belief. It can be black magic, it could be other related things. So how do we deal with that? You're asking. Well, ultimately it is linked to schema again, right? What schema do you think is at the heart of magical thinking?
Probably I could guess the vulnerability to harm, fear.
Yeah, I have a case, you know, and there was this very successful businessman, you know, but he's having all this conspiracy theory that he believed in, you know, with the COVID. You know, I know there's a lot around here, but he particularly is very susceptible to that. You know, it is all planted by China and all that, and you know, or the American. There are all sort of theory going on, and he then when we do a bit of clinical history, and that is why you need to do clinical history, right, to find out what we call, in fact, developmental history, right? Developmental history is where how the patient developed as a child. What were the you know, I talk about the painful memory, what sort of painful memory they have, the trigger memory. So you need to get this developmental history of the patient, what are the significant events, right? And what we found out was for him, his mother, right? His mother seems to be having some narcissistic personality disorder, right? That means she wants to be worshipped. She wants to be thought of, you know, as the person having all the answer and you know, to be like God, to be worshipped. So he would keep on frightening the young boy, you know, that there are danger everywhere, but only your mother can save you, you know, only your mother can help you, right? So he grew up with this environment, and which is then have this a few of this schema, which is one with vulnerability to harm. The other is mistrust and abuse schema. All right, I have it here somewhere. Mistrust and abuse. So he doesn't. In fact, wow, this is like not a coincidence. The top schema come out: mistrust and abuse. All right, you see it, mistrust and abuse schema. So he like mistrusts everything. Yeah, because he was abused. So that's why he have all this conspiracy theory. Is directly linked to how he grew up with the mother, who make him fearful of things, you know. And so we therefore need to help him to see that. All right. So this is his schema operating, or his you know, thing about conspiracy, about you know, magic out there. It's all part of the same thing. All right. So we need to change the schema for him, because he grew up with a lot of mistrust, and that's why he feel the, you know, all this black magic is the, you know, is real, but it's just a form of, you know, his schema talking. Yeah. So this is ultimately how you deal with it, but you know, but if you keep on challenging it, you know, he will keep on coming up with different way to challenge you back, and you know. So this is why CBT, you know, you need to really come down to the core belief. Otherwise, you just lock in, you know, an intellectual exercise with your patient about, you know, the challenge. Yeah, you need to get to the core of it, to the bottom of it, and you need to do it in a Socratic way so that the patient can see the irrationality themselves. Okay, makes sense to you?
Yes, doctor, thank you.
No worries.
Doctor, maybe this will be our last question, but coming back to our retrenchment counseling, yeah.
Yes.
The what happens if the worker that has been selected to be retrenched yes, he accept the situation when the what we call majikan tu bagi tahu, make the decision that okay, you have to go. He accepts it, but just on the surface actually, but in within himself he is still like denying of his emotions, of the changes that he would face throughout his career, and what will happen uh, for his financial status or family management of the family. So how do we deal with it in our counseling session, doctor?
Right. So there you are saying that there are a lot of denial, right? About the impact. So is the employee denying all this impact on his family, or he's worried about the impact on the family? Which one is it?
Maybe he's denying that, denying of his personal emotion, because he has to deal with a bigger picture, with his
Yes.
family financial
Right.
status and everything. So
Yeah.
the process of change, do we actually deal with it in this retrenchment counseling?
Yes. In fact, change caused the most anxiety, right? And that's why retrenchment caused a lot of anxiety for the employee, right? Because it's one of the biggest change. Imagine you've been working, on the job for like many years, and now you are retrenched. So one way is not to talk about it, to protect themselves. So yes, helping, but you need to create a safe place to help the patient to be able to be comfortable, right? Because you need to help them expose their vulnerability, and they need to be comfortable to expose their vulnerability. Yeah, so you need to make them feel safe to connect with you on that, and share with you their vulnerability, that they are in fact fearful. So this is what we were talking about just now with Kamini, get to the primary emotions of fear, that they're actually, afraid, which they want to hide, because that is very vulnerable, right? But unless I get to that primary emotion, we cannot start to help them. Yeah. So that is the skills of the therapies to do. And this is why, we were talking about art therapy just now, using art. All these are very good, way to help patient relax, do some drawing, and you can do that to make them feel safe. Okay.
Doctor, what about teaching acceptance?
Yeah.
Teaching them to be in the present, to accept the present moment, and then to think about what's the next best step.
Yeah, like mentioned, to be in the moment is difficult with patients who are anxious, to stay in the present, it is still difficult, that there are practices, mindfulness practice, meditation, designed for that, but that is not easy to do when you are anxious, right? So it depends on the condition of the patient. If they're having an anxiety disorder, it's almost impossible to do that. But that is a good objective to do, certainly, for normal people to have so that will help you with your resilience, all right? But when you have a disorder, to do that, it is very much of a challenge to practice that. There's a form of therapy called acceptance and commitment therapy by Chris Hayes. right? You can just check that out. It's about acceptance, but he has other way to get acceptance. Like he will sing a song, he will make a joke at himself. You know, there are different ways to use apart from the just meditating to accept, right? So that is more plausible to do that, to use a more like a creative, active ways of acceptance. Yeah, so that is and that way has been used a lot in addiction therapy as well. Acceptance, commitment, motivation interview. All right, great. We will continue on in another lecture next month. For those of you who still have a lecture, but for this segment, I pass you back to Liana.
Yeah, thank you so much, Doctor, for your time, for your explanation. So yeah, thank you so much. Maybe that will be all for today, Doctor.
Yes, well, thank you for facilitating, Liana. Great to see you and great background.
Thank you so much.
All right.
Okay.
Take care. Yeah, bye-bye. Have a nice day.
Everybody, bye-bye.
Thank you very much,
Bye.
Doctor.
No worries. Take care. Bye-bye.